like to, without wasting time, I would like to say, throughout the year, we have witnessed magic of Vaidehi. And now we are going to witness the magic of magician from Egypt. And was few lines for him. He came in 2010. He saw, he won. Again, he came in 2014 and 16 and roamed all over India. He talked, he smiled, he laughed, he talked, he did everything. And again, all gynecologists from the India loved him. And he visited India again and again. So actually, this person really is a very different and very great friend of mine. And you know, the tagline is always, it is like that. And especially I would like to mention, this time there were so many problems. Because of COVID, the meeting was rescheduled. Again, the program was changed, but he kept his promise and he came. So that's why Dr. Osama, the name is Dr. Osama. So hats off you, Dr. Osama, and he's there to give his magical talk on magics of hysteroscopy. I would request Dr. Gandhi to introduce him formally.
Shobha ma'am.
Shobha ma'am, you are there?
Shobha ma'am, kindly unmute yourself.
Is she still the co-host? She's unable to unmute.
Yeah, she is a co-host, ma'am.
She's there. I think she was there.
She's there. She's trying to unmute.
You can ask the gynecologist next door, who is Dr. OSAMA SHAWKI. We know him very well. And we all love him very well. And really, we are eager to listen him.
Let's do one thing. Let's move ahead. And once she's able to unmute, then we'll ask her to conclude at the end. Dr. Osama, we're extremely sorry to have kept you waiting because of the initial glitches of the technical issues of with Dr. Evita Face. We are running a little late, about half an hour late. So sorry for that. Sushma, I request you to begin the session. Once Dr. Shobha ma'am is able to unmute, she can conclude. Please go ahead.
We all know that he is from Egypt, from Cairo University, and he has done many workshops in Egypt and all the countries. He moved in all the countries and did so many things. He has written one book with me, and so many credits are there with Dr. Osama SHAWKI. So I think he doesn't need any special introduction, but still he's our special guest, special for the Nagpur and the Nagpur Hysteroscopy Carnival. So Dr. Osama, I present you here. So floor is yours.
Professor Osama?
Yes, namaste everybody. Good morning. Hello, do you hear me?
Yes, sir. Loud and clear.
Do you see my face?
You will have to lift your screen a little bit. Yeah, perfect.
Do you see my Sherwani?
Yeah.
Oh, yes.
Well, a very lovely good afternoon in India and good morning from Egypt. I am overwhelmed. The thoughts in my mind is more fast than my tongue, and the emotions in my heart is very tremendous. I want to shake hand and kiss each and every one. Yes, you. Sushma, where is stood here? Amog, where is your dad? Okay. Where is Lakshmi and Anil and Sunil? I miss you very much. Well, without taking much time, congratulations for your achievement. In this difficult time, you could make something really honorable, valuable. I looked at the program. This is a very packed program with everything that gynecologists, this extravaganza for gynecologists. And for me, to put me to speak after a Bollywood star, that's very difficult, Sushma. You should prepare me for that. I went to Google in the morning to search about Sonal, okay? I'm saying her name correct, Sonal or Sonali?
Sonali.
Sonali, okay. I went to Google and I was so mind blown, okay? And I thought that such talk from Bollywood stars could be boring, you know? But once I started to listen to her, this lady is not only beautiful in the face, but in her mind and her heart. She's very smart. She gave us a lesson about life. I think each and every one should learn from her experience. So I enjoyed her speech. And Sushma, please tell this great actress if she wants to learn hysteroscopy, I'm ready, okay? I'm ready.
Sure.
I am ready, okay? I'll come tomorrow. I'll come tomorrow, okay?
Okay, I will convey your message.
Oh yeah, please, please. I'll bring the equipment and everything. The tower is a gift from me. Okay, okay. So should I share my screen now?
Sure, sir. Please go ahead.
Okay. So at any moment, if you don't hear me well, just let me know, Amok, because sometimes connection is going bad. So let me know, all right?
Sure, sir, sure.
So shallow, shallow, shallow. So once again, namaste, good morning, welcome friends. And because we started with a Bollywood star, so I'm extending this with a Bollywood style of presentation packed with skills, science, experience, and practical science, not just tables and graphs and statistics and guidelines. So from the land of history, from the land of the pyramids, from the land of the most ancient civilizations, from land of history, I am bringing you today hysteroscopy. First, I want to share with you some lovely moments or memories. I wish each and every one to share this feeling with me. My dear friends, in the life of every person, there are certain turning moments in his life. There is a turning point in his life from just steady, normal, boring life till a moment he is standing on the launch pad of a rocket and suddenly poof, he is in the sky. This turning point in my life was Nagpur. Yes. Let me remind you, Amog and Sushma, the story was almost more than 10 years ago. I was giving a lecture in a congress in my country here, and I was actually going from the lecture to the airport, and I was busy. I finished my lecture and quickly pulling my suitcase, going to the airport, and then I saw a very humble, respected man coming after me, trying to pull my hand and speak, and I was in a hurry. He said, "Sir, I want to have a talk with you." I told him, "I don't have time, I'm sorry." He said, "My name is Dr. Shimoti. I am from a city called Nagpur, and we are arranging an event called Fertivision." I didn't know where is Nagpur. I didn't know what's Fertivision. The man was so sincere. He said, "Sir, today you showed us in the lecture something different than what we used to see in the cavity of the uterus. I want to bring you to my friends and my people in Nagpur, and you show your work." I thought it's just a compliment, social compliment. I gave him my phone number, my email, and I forgot. Then I received an official invitation. I said, why not to go to India? It was my first time. India, to us, to Egyptians, is the land of charm. It's the land of beauty. It's the land of Ashwarya. It's the land of the great civilization. So I want to go. So I took Air India, Cairo, Delhi, and then Jet Connect airline, Delhi, Nagpur. At that time, there was no Indigo. And then I landed Nagpur. And when they met me there, they said, "Sir, we have little problem that in your session, there are other 2 international guests, but they didn't come. So would you mind to take the whole session?" I said, "But this is 3 hours. How can I speak for 3 hours? I'm afraid it could be boring." So Dr. Chimoti was very kind, said, "No, sir, you can speak for 3 days and it will not be boring." And that was the launching pad, getting me up to the stars. And at that moment, everyone saw my work. And that was the start. And then came the most close lady to my heart after my wife and my mother. This lady, okay? She was so shy, so low profile, so polite. And she said, "Sir, my name is Sushma Dushmukh, and that's my husband, Sudhir." Sudhir means a lion, but he looks like a little bird, actually. He's so kind heart. And she said, "You reinvented hysteroscopy to us. We have never seen the cavity of uterus like this. So would you mind that we make an event?" And that was the birth of Nagpur Hysteroscopy Carnival. Everybody copied us. And that was the birth of or rebirth of hysteroscopy. And we did a live surgery. And this picture tells you the meaning of hands-on. Hands-on doesn't mean your hand on the instrument. No, hands-on is my hand on your hand on the instrument, and you get the feeling. This is my personal, special, unique technique of teaching, that you get the feeling from my hand, the sense of touch, the little movement, and displaying this to everybody. It was a mania about hysteroscopy. And then that was the start. Every week, I got an invitation. Till just before the corona, 168 training programs in India with more than 3,000 challenging operations. Hands-on training for more than 5,000 gynecologists. And I was a regular guest in the AISOEG Congress. You know, AISOEG, there is about 10,000 doctors. So I'm proud that I achieved the Guinness Book of Records, shaking hand to 80,000 doctors in all India. And then I found myself more famous than Salman Khan and Shah Rukh Khan, okay? The posters of my visits was like a movie posters, and I received by garlands and flowers. Look at this picture, okay? Okay, we need to make a Photoshop and remove this gentleman, okay? Because, all right. And I think this picture before the COVID time, can you see where I am? This is me. Sushma, you made me a star in your country. And that's something I will never forget. And if you look at the faces, the smile, the feelings that everybody feel happy, confident that we learned something new. And this picture is in my country. And I received more than 150 Indian doctors in my country. This is Jaydeep Malhotra and Dr. Narendra. They were in my house, in my hospital, in my operating room here. So, hysteroscopy is my lucky charm. Hysteroscopy made me known, made me loved by all people of the world. So today I'm coming to tell you, or to reopen or to rediscover what is hysteroscopy. Let's redefine hysteroscopy. Listen, my friends, this is an advice for each and every beginners. Okay, every gynecologist started his endoscopy career. When they start to do laparoscopy, they know their ambitious, their goal, their limit. The majority will know that we will go by that laparoscope, have diagnostic view, to do some minor procedures like ovarian cyst or ovarian drilling, and that's all what we do, and they're happy with that. And very few will jump to be like Shailesh Puntamaker, like Hafiz Rahman, like Nikita Trahan, that they go to fight with 5 kgs myoma and remove uterus in a previous 5 cesarean section, or to do difficult endometriosis. So in laparoscopy, things are clear. But when beginners start to learn hysteroscopy, they think that once we can go in and out, then tomorrow we can do the large septum, the big myoma, and the Asherman. And here come the tragedy. My vision and my classification for this kind of surgery, hysteroscopy, you have to distinguish between hysteroscopy and intrauterine surgery. Intrauterine surgery is something totally different. The big myoma, the Asherman, the huge septum, this is not hysteroscopy. Different equipment, different skills, different complications, and different learning curve. So my job today is to tell you how can you develop yourself, when to stop and when to continue. I get very crazy, Sushma, when I meet some doctors and they say, yes, we are starting hysteroscopy, but we don't do the big myoma, we do just the Asherman. I get crazy. Come on. The Asherman in hysteroscopy is equivalent to the frozen pelvis in laparoscopy. How can you think it is easy? People think that, okay, we can go and play by the scissors. Some people say, okay, yeah, I'm starting hysteroscopy and I will do, it's easy to do the myoma resection. Come on. Laparoscopic myomectomy is 100 times easier. People think that myoma by hysteroscopy is something easy. In laparoscopic myomectomy, you can spend 3-4 hours working slowly. You have an assistant, you have a cameraman, you have a uterine manipulator. And if you fail, somebody can continue. But in hysteroscopy, you cannot. In hysteroscopy, if you stay 30-40 minutes, patient die. You understand, my friends? You cannot work for a myoma for 30-40 minutes. You are limited by the time and the fluid volume. So here, everybody should learn when to stop and when to continue. And you have the right to have the ambitious to do the large myoma and the big septum, but you have to be prepared for the long learning curve and to be really skilled in the technique. Starting hysteroscopy, the success is in the access. In laparoscopy, you just put the trocar and then the telescope and you see everything. You inflate the abdomen and then you go by the lens and you see everything. But here in hysteroscopy, there is no distension before entry. And the biggest challenge is the angle of the lens. In hysteroscopy, it's almost 30 degrees. So when you are moving forward, you see only up. And you cannot see front. You cannot see the internal os. So you get confused. How many times this confusion happened? 100%. With every beginner, with every expert, even with me up to date, till now, sometimes I get confused. When you move forward, you see only up. So you cannot see the internal os in front of you. So you raise your hand to get a good rounded circular view of the internal os. And then when you push, you hit the posterior wall and you make a force track. Another thing, learning about how to control and play with the fluid pressure for dilatation. In the old time, before I started my concept of hysteroscopy, people used to dilate the cervix with Heger dilator, and then they go by the telescope. Once you dilate the cervix and you do friction, there is a lot of shreds and blood clots and little blood. When you go in again, you cannot see anything. And this is the very common mistake. You can see here is the internal os and how many false track, double false track, because the surgeon was not prepared. He doesn't have the mental correction of the 30-degree angle length. Again, how many times this happened? With everyone. Don't deny it. It happened with everyone. Look at this. This is the proper internal os. False track, false passage. So this is the difficulty, the challenge in hysteroscopy. I get crazy, my friend, when people say hysteroscopy is easier than laparoscopy. Not at all. If you think this, you are not doing proper hysteroscopy. Then, how to look on the lateral wall, how to see the angles. In laparoscopy, you move the telescope like left and right to see the ovary left and right, okay? Left and right at the next. In hysteroscopy, you cannot do this movement. But because of the 30-degree angle length, you have the privilege to rotate the telescope. All movements in hysteroscopy is rotation. You see my hands? It's all rotational. It is not like this, and it's not like that. It's all rotational and very gently. By rotating the telescope, you can see the lateral wall. So you hold the camera in one hand, the camera and hysteroscope in your left hand, you hold the light cable and you rotate the light cable. When you rotate the light cable, the camera is rotated. So you can see right and left. If you do full rotation upside down, you are looking to the posterior. This video shows how you can maneuver and you can inspect the trunk cavity. Some different way. This is another technique I'm teaching. This is the way you hold the camera. I call it the Shawki grip. Or look at this beautiful technique. These fingers are more tactile sensitive than the other joints. So the movement will be very fine. Look at this. This is the cigar grip. The other grip that I like is, Yahya is laughing, okay? This is I call it the Shawki grip because you have an access to the focusing wheel and you can see the control of the camera. Never hold the camera like this. This is not for hysteroscopy. Back to the monitor, Yahya. And now, so holding the camera like a cigar like this, so you can, look at it. Please, everybody learn from my hands. This webinar is not to give you just lecture. It's for tips and tricks and skills. When you hold the camera like this, like the cigar, so you can rotate. Sometimes, Sushma, this advice for you, because you are my favorite colleague, I want to give you the secrets. Sometimes when you rotate the camera, okay, your wrist locks here. You cannot rotate more. Look at me. Don't forget that you have an elbow. So raise your elbow up. Look at this. So just raising your elbow up will complete the rotation and you can see the posterior wall. Enjoy this video. So this is how to rotate the camera to see left and right. The most frustrating problem in hysteroscopy that everybody complain, we cannot see well. The view that frustrates most people, I call it the Japanese flag. The white monitor and just a red circle, like they don't have any view inside the cavity. So these are some of the videos I quoted from other colleagues to show what does it mean frustration during hysteroscopy. Collapsed cavity, There is no vision, a lot of shreds, and you cannot see any anatomy inside. It should not be like this. It should be different, like that. So the most important issue in endoscopic surgery in general, laparoscopy, hysteroscopy, arthroscopy, whatever, the most important issue is to create the space to be able to enter the cavity, to achieve the space, to be able to move inside and to operate. So distension is the key of success of any endoscopic procedure. In laparoscopy, distension is not a big challenge. Why? Because if you put the varus needle or the trocar and you operate new insufflated, abdomen is distended and there is no leakage. One more thing, in laparoscopic surgery, your distension medium is carbon dioxide. There's no absorption. There is no risk. You can keep operating slowly for 4 or 5 hours. So there is no rush. But in hysteroscopy, there is a big challenge because you have 1, 2, 3 orifices with a continuous leakage. It's continuous leakage all through. So attaining or sustaining the distension is difficult. Another thing, the distension media here is fluid. It goes into the circulation. So you don't have the privilege of working comfortably for a long time. You have to finish. So remember my word, there is a difference between hysteroscopy for everybody. Everybody can play inside the cavity to remove a missed IOCD, to do diagnostic, to do biopsy, to remove a polyp. But intrauterine surgery, it's another issue. This is my classification for your safety and for the patient safety. So you have to sustain the pressure inside. Then we come to the big debate. How much pressure is needed? There is no number. It differs. It depends on the size of the uterus, on the kind of pathology, and the size of the pathology. For a small myoma, different than the large myoma. And then come the biggest problem in my life. My friends know this problem. The issue of intrauterine pressure and the battle between me and some big tycoons, European fuckers. My proof is not scientific. My proof is logic. No paper, no publication, no article. It is just logic. The intravascular pressure, the blood pressure is 120. This is the arterial blood pressure. So if you're doing hysteroscopy and you start to cut into a myoma, what happens? If the intrauterine fluid pressure is less than 120, the blood will flow inside the uterine cavity, like this picture. It is not a dangerous bleeding, but some little blood will come into the cavity. It will mix with the fluid, everything will look red. The cavity is not suitable for surgery. So what is the solution? You have to exceed the arterial blood pressure, to tamponate the vessel, to avoid any trickling of blood, and then have to finish the surgery. You have to remove the myoma at the septum in short time, because at that time, the absorption of fluid is too much. So we are in a friendly meeting, so I can tell some of my personal secrets. One of my colleagues in Europe was very aggressive towards me. He's very famous name. And he has his invention of a fluid pump of hysteroscopy. He was always attacking, saying, OSAMA is crazy, OSAMA is teaching wrong. And in big conference in Europe, he said something heartbreaking to me. He said, I know 2 cases died in India because of using this technique of OSAMA, which is unfair and not true. Patient can die from any reason. And I faced a big challenge. It was the challenge in my life. Even in some events in Europe, they avoid to invite me, so I cannot talk about this. They said, don't bring Osama, he's teaching wrong. Last month, this colleague from Europe, his invention pump with a maximum pressure of 120. It was a failure, in my opinion. It was discontinued from production and withdrawn from the market because many patients died in Australia. It's on the news, in the public. So I'm not saying that they died because his machine is wrong. No, but even using a low pressure, the patient can die. If you continue working for a long time with large volume of fluid, the patient will die. It's not a matter of pressure. It is a matter of duration of surgery, volume of fluid, and pressure. So don't focus on the pressure alone. Operating with a high pressure for short time, you can finish and you can do the surgery. This is an example of myoma resection using a pressure less than 120. Look at the bleeding. How the surgeon can continue the surgery with this collapsed view? It is impossible when you compare it with that view. Why there is no bleeding in this case? Not because of electrocautery, but because of the fluid pressure. I will show another advantage for fluid pressure, not only to distend the uterine cavity, but to be able to enter the cavity. This is a case of a huge dumbbell-shaped fibroid, 2 parts. The lower part of the fibroid is filling the cervical canal, obstructing the internal os. How can you enter with a collapsed cavity because of low pressure? I am playing with the pressure, low and high, to show you the difference, to show you the value, to show you the need of a higher fluid pressure to push the pathology and be able to enter. The lower part of the myoma is bulging from the internal os. This is the tiny polyp, forget it. So please observe and appreciate how to be able to use the pressure to go in. Look at the RBC. So it only looks impossible and strange until someone thinks different than the others and prove it is possible. So I'm happy that now the concept of changing the concept of intrauterine pressure is accepted, and many companies changing the design now. Let me take you for another world of hysteroscopy. It's not only when you love something, you invent indication for it. So I thought, and I think, and I invented new indications for that tool to look inside the vagina, to examine the cervix, to examine the uterus, and the proximal part of the fallopian tube. Colposcopy is the technique that you look to the cervix through the vagina. But gynoscopy is to examine the vagina, examine the cervix and the endocervix, all the way up to the fallopian tube. The standard gynae examination since many centuries was like that. It's very strange that up till now, we are using the same tool, this ugly metal speculum, to look inside the vagina. The patient doesn't like it. The patient feel afraid from the attitude of the doctor coming like that and holding the metal instrument. The patient is terrified. And then when you put this tool, the vaginal speculum, you cannot see the vagina. You see the joke? Ironically, when you put what we call it vaginal speculum, you only see the cervix. So this is very frustrating. This instrument should go to the shelf of the museum. Let me show you another comfortable, beautiful technique of my mind to examine the vagina. Simply in the office, no speculum, no teneculum, just insert the 2.9 telescope. It's very narrow, 2.9 lens with the sheath. It's almost 3.4 or 4 millimeter. Open the water, examine the vagina. Look at this. Look at the vagina Roger. You can examine each and every corner very clearly. Nothing is more obvious than this. Look at this case. This case I did in the city of with Dr. Brajbala Tuweri. Patient was postmenopausal, severe pain, severe vaginal pain, and nobody knows why. This is atrophic vaginitis. Atrophic vaginitis. You will never see it when you put a cascospeculum, and they're superimposed with the typical strawberry. This is the strawberry trichomonas vaginalis. Even you can examine the cervix better than the colposcope. Look at this video. This Angelina Jolie's lipsticks. This is much better than any colposcopy view. Even more, you can go inside the cervix. This is the vagina. What is this? Something you can never diagnose by standard vaginal examination. This is a case of severe pelvic pain. Look at the rare cases that you miss by not using vaginoscopy technique. Yes. Yes, this is a deep infiltrating endometriosis affecting the vagina and the cervix with cystic lesions like this. Chocolate blood count. So without my technique of vaginoscopy, you will never be able to diagnose these lesions. And when you go from the external os, you will have a beautiful view of the columnar epithelium, the arbovitae, the beautiful endocervix, and you can get diagnosis for things that standard colposcope cannot show you. And this is a nice Nabutian cyst. So still, we are not inside the uterine cavity. This is a new applications. One of the very nice applications of this tool is intravaginal surgery. That's a longitudinal vaginal septum, you can see. And in the past, people used to cut by the diathermy or the scissor like this. But look at the view. Look at the view with the vaginoscopy technique. Distension of the vagina, stretching the septum. That's a longitudinal vaginal septum. And cut. So again, this is my pump. You need enough pressure to distend the vagina to be operate inside the vagina. Please, please, my friend, enjoy this new horizon in gynecology, intravaginal endoscopic surgery, okay? We have used endoscopic surgery into the abdomen, into the uterus, but now it's intravaginal endoscopy, all right? So especially in some cases like virgins, in my culture, I don't know about India, keeping the hymen and the virginity is very important. So what to do in patients like this when they have a pathology inside the uterus inside? This is the hymen. We can go very smoothly and safely through the hymen, distend the vagina, and then you can see the pathology inside. That's a pedunculated small myoma coming from the surface. So how can you remove this without violating the hymen, all right? You can see, and you can climb up until to see the pedicle, okay? This is the pedicle of mine. You see, Sushma? This is the pedicle coming from inside the cavity of the uterus, like a ponytail of the hair. So if you cut this pedicle, the myoma comes out, right? This is another case, large pedunculated mass from the external os, and this is intravaginal surgery. Intravaginal surgery. You can see the pedicle and then you can cut. So as you have seen, the applications are much more than people used to think. Fluid pressure is not only for distension of the uterine cavity. You know, Sushma, that's why the European didn't get the message from me. They thought that OSAMA is using a high pressure that will explode the uterus. That's absolutely ridiculous. No, you need the fluid pressure for many other uses and benefits. You need it to go through a narrow surface. Listen, my friend, some statements, put it in your mind. Never use Heger dilator. Your dilator is the fluid pressure. Some cases of cervical stenosis or cervical adhesions, the fluid pressure will help you to avoid this false track. Look at this picture. This is the pressure you need to go from the cervical canal. Once you're inside the uterus, you can decrease the pressure. So how come you give me a machine with a maximum pressure of 120? It will not help to go through a stenotic cervix. Please observe this beautiful demonstration for the value of fluid pressure to go through impassable cervix. No more difficulty in dilatation of the cervix. Cervical canal. Stenosis of the internal os. Adhesions. Please appreciate the value of the pressure to give you the way to enter safely without any force track, without perforation. Watch this, Amog, look at this.
Wonderful. Excellent, sir.
Excellent.
Better than a Bollywood movie, sir.
Very nice.
You love this, I know you love this.
Amazing.
Sushma, look how you enter under vision. And now you are in. Do you love this, Amog? You see?
Yes, sir. Wonderful surgery, sir.
And please, Amog, I forgot to tell everybody that this Sherwani is a gift of your blessed soul mother, okay? I still have it. This Sherwani from Jade Blue in Nagpur. Thank you. Okay. So you need the fluid pressure to unglue the adhesions, because the water pressure know the anatomical plane better than you. If you use your hand with the metal Hager dilator, you definitely go into the wrong side. But if you use the power of water and then you follow the water, again, Sushma, give a chance for the water to go first, and then slowly you follow. Look at this case, which was done with Dr. Brajbala Tiwari in Indore Life Care Hospital. It was zero cavity, like this. Look at this. Corneo here. Now we go to the other corneo. You see that?
Yeah.
You see that? This is the other cornea. It's a first fluid pressure to show you the way, and then bum.
Wonderful.
Are you happy, Amog, now?
It's so wonderful.
Yeah.
Just like champagne bubble sign, this is a cotton candy sign.
And then, after expansion of the cavity, we do an genius research, which is, look at this. This is a new research, which is injection of PRP in the endometrium. Now you will see the PRP needle. This is. It's the same ovum pickup needle, and I inject the PRP here. This is before, and this is up.
Wonderful, sir.
If anybody knows Dr. Brajbala Tiwari in Indore, call her and ask her what happened. This patient got pregnant with twins with an IVF, and her story was in the newspaper. So hysteroscopy can do miracles, but you have to understand how to play with it. So for infertility, does it have any value? Some people put question marks. Do we need hysteroscopy for IVF? This study will tell you the answer. This study was done for 520 cases of a failed IVF. When hysteroscopy was done, 40% of them, there was a problem inside the uterus. There was a missed polyp, short septum, little adhesions. And correction of this intrauterine lesion resulted in improvement of pregnancy rate to 50% instead of 20%. So please, no more argument about should we use hysteroscopy or not. The argument should be how to learn hysteroscopy. I'm sorry to say, Sushma, and you understand me, many people say, yes, we can do hysteroscopy. It's easy. Once they say it's easy, you know that they don't know anything, all right? You should learn. We reinvented hysteroscopy, okay? What are the possible findings inside the cavity? Polyps. Evidence-based medicine tells that any polyp more than 1 centimeter should be removed because it affects implantation. The problem is not to remove or not to remove. The problem is how to remove. Still, people do blind curettage. With blind curettage, you will never remove the polyp from the base. You will hit the polyp and take some tissues, but the base is still there. Look at this. You can do it as an office procedure. You should learn how to use the scissors. From the pedicle. You should learn, everybody, that the use of the scissor is not only to cut. Sushma, people still think scissor is only to cut. Scissor in hysteroscopy is to retract. Use it to retract, to rotate, to dissect, to move, to push, and then to cut. So all these skills you have to learn. Is it easy? No. Is it impossible? No. But you have to learn it well. Don't think that I can play with the scissor like anything. So reach the pedicle. Observe, Amog, how I will use the blades to retract. Look at this. To retract the polyp and rotate and just keep at the base and push. It is a combination of cut and push, not only cutting. Push is very famous word for gynecology. Push, push, and then polyp is there. I will tell you a little joke about polyp, Sushma. I was doing a workshop in Cochin, and I was doing polypectomy with the scissor, and in the other room was my beloved brother, friend, Hafiz Rahman. Hafiz was doing a TLH in a difficult previous 4 cesarean section. So at the lunchtime, Hafiz came. He was joking, but said, Osama, I'm very angry. Why? The whole crowd was in your room while you were only doing simple polyp. And in my room was a difficult case, and there were little people watching. I said, listen, Hafiz, because what I'm showing them is what they do every day, what every gynecologist is doing. But very few people are doing your job to cut the ureter and cut the bowel and re-anastomose. This is nice, but this is not the everyday job for gynecologists. One more thing. What you are doing, Hafiz, by cutting the bowel and the difficult cases, any surgeon can do. Any surgeon can do. Shailesh can do. Akshaynath Kani are doing it. But this little polyp, which you think is little, surgeons cannot do. Only gynecologists. So that's why gynecologists are happy. They are doing things that surgeons cannot do. And a polyp is everyday problem you meet. And we have to stop doing D&C. Don't be like a blind man. It is a deliberate crime. The chance to remove a polyp by blind curettage is only 30 to 40%. Let's move quickly to congenital uterine anomalies. And this is the most recent classification by the Esri. They put the anomalies from type 0 till 1, 2, 3, 4. So type 0 is the normal. So type class 0 or type 0 uterus is the normal uterus. Okay. This is U1. U0 is normal uterus. U1 is the dysmorphic uterus, which is the shape is abnormal, the T shape or the hypoplastic. U2 is the most common anomaly, which is the uterine septum, whether short or long. U3 is 2 separate cornua, the bicornuate uterus. And then we come to U4, which is a unicornuate uterus with or without rudimentary horn. So the normal uterus, my friends, when you are by the hysteroscope standing at the entrance of the uterus, just at the level of the internal os, you can see the sliding lateral wall with both cornua at the view. But in the T-shaped uterus, when you are the internal os, you see only a tunnel. You cannot see the cornea. So this is how to diagnose. Is it common? In general population, almost 6% they have uterine anomalies. But if you look to a special group like infertility group, up to 14%, with patient of recurrent pregnancy loss, almost 1/4 of them, 25%, they have congenital uterine. When you got this HSG with the patient, and it's confusing this Bugs Bunny ears. Is it a septum or biconic? The patient asks you, sir. Some doctors told me it is a wall septum. Some doctors, they said it's a double uterus. So by hysterography, it's very easy. If the angle between both cornea, this is the angle between both cornea. If it is less than 90 degrees, 100% septum. But if the angle is obtuse, more than 90 degrees, we cannot tell. Again, if the angle is narrow, 100% septum, you don't need to do any other investigation. But if the angle is more than 90 degrees, you cannot tell. It could be broad septum, it could be biconic. In that case, you have to do another investigation, and the best is 3D ultrasound. This is the triple line of the endometrium on both sides, and in between there is an inverted pyramid. That's a septum. If you inject water during the sonohysterography, you will have a beautiful view of uterine septum. And in this case, it's obvious, one endometrium cavity, other endometrium cavity, okay, and in between here is black. There is no tissue. So this is two separate cornea. And in this view, there are different categories of uterine septum. Let's put the landmark. Look, Amog, this is the fundus of the uterus.
Yes.
This is the internal os, and this is the tubal ostium. So here the septum is reaching midway between the fundus and the internal os. So this is a short septum, incomplete septum. Here the septum going all the way around till the internal os. All right, that's the septum. And here uterine, cervical, vaginal septum. When you have this hysterography carried by a patient, don't rush to the diagnosis of a unicornuate uterus, although it looks unicorn. Some or many cases of complete septum, the doctor doing hysterography push the cannula in one cornea. So he have this false impression of unicornuate uterus. If you pull the cannula outside, then the dye will go into both cornea. Actually, this is the same case, but here was a wrong view, and this is the correct view. So 3D ultrasound is the must for the diagnosis of congenital anomaly, and the technique by the resectoscope that I'm very proud that I teach everybody. They do it even better than me now. I'm proud of Sushma, I'm proud of Amok, and Manish. Where is Manish? Manish and his wife Charu, I think, if I'm correct. I'm just showing off, I know the names, all right? And Dr. Lakshmi, they are doing it very well. So we start from the lowermost point and move the electrode from side to side. Some secret tips, my friends. If you are using a larger resectoscope, you have to dilate the cervix enough to allow easy go in and out. Don't dilate too much, otherwise there will be leakage, collapse of the cavity, and don't dilate little because the internal os will be tight. You cannot move the telescope well. And you should achieve this view, Amok. Look at this. This is the septum stretched. Here is the tubal ostium, and this is the electrode. So the electrode should be exactly parallel to the level of the ostium. So you are not much up, much down, and move the electrode from side to side. Please, my friend, don't use this push technique. If you push, you touch the septum at different points, it's irregular cut. And if you push near the fundus, you can perforate. Always keeping the ostium at your eyesight as a reference point until you finish when both tubal ostium at the same time. So definitely septum, I can speak for 2-3 hours. It's in the workshop. There is a workshop only for congenital anomaly, but this is the final view. And no need to put a balloon or to give an estrogen or IC. This will heal very soon. So let's enjoy septum surgery. Ostium. This is the fundus. I will give you some secrets here. When you reach the fundus, my friends, or the more you climb up, listen, this is My secret's only for Nagpurians, okay? When you reach near the fundus, decrease the fluid pressure a little bit and decrease the electrocoating. At the start, you can use freely high pressure, high electrocoating. But the more you climb up, decrease the fluid pressure and decrease the electrocoating. Otherwise, perforation can happen from the fluid pressure. Or otherwise, the electric current can make a spark and spread behind the fundus without perforation, and it can affect the bowels. So septum surgery is a plastic surgery. It is not something little. So this is the final view. Look at both tubal ostium. You can add some little adjustment, like the hairdresser cutting the hair. You remove a little bit left, a little bit right. Okay, here I'm working very, zoom in. When you zoom in, you can see the fibers of the septum. By the way, septum is muscle fibers. This is my theory published since 2014, and everybody is copying it now. Sushma know the secret about this, okay? So, because the Europeans are published this only last year, and they say that they discovered something new. It's in the publication since 7 years by myself. So this is at the end of surgery, this is before, and this is after, okay? We move to another technique for septum using scissors. Despacito, quiero respirar tu cuello despacito, deja que te diga cosas al oído, para que te pierdas si no estás conmigo. Despacito, quiero desnudarte a besos despacito, firmo las paredes de tu laberinto, y hacer de tu cuerpo todo un manuscrito. Let me confess a secret. This case is not performed by me. It is by very humble young doctors in Guwahati. I was assisting her and she did this septum. She did it very well. But she was a little bit afraid because she was afraid of perforation. I was standing next to her. I was holding her hand and show her the tactile sensation until she finished the septum very well. Final view. This is the final view. So I will show you the healing of the septum. It doesn't take 2 cycles. This area will be covered by healthy endometrium, regeneration, and new blood vessels. Enjoy. Second look after 1 month. Third look after 2 to 3 months, complete healing. Three cycles after surgery. Zindagi. So this is the uterine septum. I'll move to another application outside the uterine cavity, which is the fallopian tube in infertility. How to assess the ostium. By creating bubbles, and Sushma know how I do this. And Sushma, this is my little secret you can tell to all friends. So there is the inflow channel bringing the water. From the outflow, I inject air from a syringe. So you create the bubbles and you enjoy this view. Sometimes this also can clean the pipes and remove some debris and cause spontaneous opening of the tube. I remember in the Nagpur Carnival, we did 2 cases, which was unexplained infertility with Sushma. I think the name of the hospital was
Getwell
Hospital. And actually, I tell you the story. Let me tell it, Sushma. Sushma told me this is a case for tubal canalization. I'm not convinced with tubal canalization. This is another story. So we did only this bubble test. Only bubble. We didn't do canalization. Only bubble test. And the patient had a previous hysteroscopy with tubal obstruction. After 4 months, Sushma sent me an email and I show it in every Congress. Osama, congratulations, the patient of tubal obstruction, she got spontaneous pregnancy. So some of the cases that I can get benefit out of these bubbles which clean the pipe. Another technique for assessment of tubal patency. That's a methylene blue injected from the outflow channel, which makes like an arrow going from the ostium. See that? Again, methylene blue flowing from the tubal ostium. So I hope you are happy, my friends. So I'm coming to the last part of my presentations about the watermelons, the melons, the fibroids. In the morning, I asked the Sushma, should I focus only on Asherman or fibroid? She said, Osama, they love everything you do. So speak about everything. So I spoke little about everything just to get the benefit for everyone. And I hope this corona will finish and I come back to my beloved city of Orange to see Lakshmi, Sudhir, Amog, Shimuti, all my friends. So fibroids, this is the latest classification by the FIGO. They put fibroids into 7 categories according to their location. The type 0 myoma, when the whole myoma bulging into the uterine cavity attached by a narrow pedicle. The type 1 myoma, more than 50% bulging into the cavity with less part deep. Type 2 is more deep intramural myoma with more than 50% intramural and less inside the cavity. Type 3, type 4, both of them are intramural, but type 3 is intramural touching endometrium. Type 4, intramural touching the serosa. Once it starts to migrate out of the serosa, it's type 5. More than 50% bulge subserosal type 6, and type 7 is the pedunculated subserosal, which is the mirror image of type 0 submucous. According to the European Society, okay, I do respect European guidelines, but they are not more intelligent than my mind. And I have been inside the uterine cavity 100 times more than them. So I respect their guidelines, but I still can modify in that. They say that only type 0, 1, 2 is accessible by hysteroscopy, but I will show you that you can do type 3 and 4, but you have to build up your skills. My friends, this is an advice for the beginners, because people accuse me that I give over courage to people. No, for the beginners, you are not allowed to break the rules unless you know how to fix it. You are not allowed to break the rules unless you master the rules first. Okay, so the technique of myoma resection simply is, first, you have to create the space. In laparoscopic myomectomy, there is no big challenge. The abdominal cavity is big. So whatever the myoma is big, still you have a space right and left to move. And you can move the uterus by manipulator. But with a submucous myoma, if it's a little bit big, the walls of the uterus are collapsed over the myoma. You cannot find the space. So first, you have to create the space like this. How to create the space? Fluid pressure. How much? I don't know. I cannot tell you. It depends. Sometimes we reach to a pressure on my pump to 300. Please don't scream. The 300 is on the display of the pump. But inside the uterus, it can be hardly 120 because of the leakage. So this was my struggle with the European faculty, that whatever you say pressure is not the real one inside the uterus. So you should be prepared with enough power in the machine to compensate for the size of the uterus and the leak. So create the space and start cutting from the most wide accessible area. Important advice, and I know that you're doing it very well, Sushma, now. When you cut the pieces of myoma, don't go in and out, in and out. No. Keep cutting and push the pieces to one side. How to push them? By the electrode or by the power of water. By the jet of water, you can hit these cut pieces and push it to one side. And keep working as much as possible until the cavity is crowded, and then you clean. Because if you keep go in and out, each time you are out, the cavity collapse. Some blood will come in. When you go inside again, the view is terrible, terrible. You'll not be able to continue research, okay? So, and also the chance of air embolism is higher when you keep go in and out. One more advice, Amog, when you cut the myoma, please don't be afraid and take thin slices, all right? You will not perforate, and you are not safe by taking thin slices. The potato chips technique will make a lot of slices, crowded cavity, and you'll not see well. And it will take more time with more risk of fluid overload. So please use my technique of wedge potato slices. So instead of cutting small thin chips, take big bite. How to take big bite? That's the electrode. Hit the myoma. You'll not perforate because the myoma is a mass and you are away from the wall. Hit the myoma and push. So by this, you will cut deep bite, like this. Look at the electrode. See how the electrodes take a potato wedge piece. Why the view is beautiful? You know, the first person who called me magician was Sushma Dushmukh. Sushma, thank you for the calling magician, but I'm not magician. I'm more humble than what you think. The magician is the person who does something outstanding that people cannot do. He can take a rabbit out of his jacket. But in fact, this trick, when you accompany the magician to his home, you will find a secret pocket in his jacket where the rabbit is there. So what I have done in my life, that I showed everybody how to get the rabbit out of the coat. This little trick. So you can do beautiful things. And this is the final view. Please, I see many colleagues, they are very proud showing their videos of myoma resection. So I always comment by saying, don't try to impress me by showing the start of the surgery. Impress me by showing the end of the surgery. Sushma understand my meaning, okay? Because everybody starts to cut few cuts, but they are never able to continue till the end. They don't see well and they stop. So you have to see this myometrium, which is the interlacing pinkish fibers, different than the white solid fibers of the myoma. Look at this. That's the myometrium. Little myoma fibers here. You see that? Pull and up. Amog. Advance the electrode. Push the electrode against the wall of the tissues and then pull the electrode halfway. If you pull the electrode all the way back, it will hit on the lens. This is the lens. If you pull the electrode all the way back, it will hit the lens and the tissue will cover the view. Only pull the electrode halfway. Still you have a good view. And then pull the whole system out. Got it? Say yes.
Yeah.
Okay. Now I show you the challenge, breaking the rules, removing type 3, not this one. Type 3 myoma, type 3, which is not bulging. But the ultrasound proves there is a posterior wall myoma in this area. So let's see how can the impossible be possible. Sushma, I want to give another secret for you. Sometimes when you insert the resectoscope and the fluid is going in, there is some bubbles. And the bubbles confuse you. You cannot see well. And if these bubbles is kept inside the cavity, you cannot continue the surgery and air embolism can happen. Now I'll tell you a little secret. I will repeat the video again. So when you have bubbles inside, rotate the system 180 degrees. If you rotate the system, the outflow channels will suck the bubbles out. Please observe this. This is my little gift for you today. Again. This is the bubbles coming. Bubbles, bubbles. You cannot rotate. You see this rotation? When you rotate like this, the bubbles are absorbed out. And then cut. Here is the myoma. This is the myometrium here. This is the myometrium. Myoma is totally resected. So the technique here is more difficult. Is Sushma hearing me?
Yes.
Now another gift for you, Sushma. Today I am exploring all my secrets for you. If the myoma is deep, okay, so what you do is, this is the loop, all right? By your hand, gently bend the loop more inside, okay? Do you see my hand, Sushma?
Yes.
Bend the loop with your hand, but don't break it. So that the loop comes from the company like this. So you can change the loop angle. So when you bend the loop like this, it becomes like the ice cream scoop. So now you can take the deep myoma. Are you happy with that?
Thank you.
Okay, now we go to the last slide, the last video, the finale, which is a case I'm very proud to show, not to show off, but to show that the impossible can be possible. What people say you cannot do, one day it will change and you can. But you should have hope, you should have perseverance, you should have skills and experience. This is a case of subserous myoma. It is not bulging into the cavity. And the patient had failed IVF 4 times. Her belly is like tram line. She was operated upon 7 times before for multiple surgery. One was colostomy, one was intestinal injury. So when she had failed IVF, despite this myoma, they were ignoring it in the start. Nobody was interested to go into this abdomen. But after 4 times of failure, they decided to do myomectomy, but they failed to reach the uterus by abdominal myomectomy. It was a frozen pelvis, and the bowels was covering the uterus. So the patient was counseled that we cannot remove the fibroid, but there is some crazy man you can consult him. So when she came to me, I told her it is impossible by hysteroscopy. I've never done it, but because of your eagerness, I will try another approach to go into the cavity and cut the fundus by a scissor and open a window for the myoma to bulge in. And that was the plan. Again, the plan was to cut open the fundus till reach the myoma and then discharge the patient home, and she received misoprostol, contracting the uterus, and after 2 weeks come back again, hoping that the myoma will fall into the uterus. So this is the fundus. These white fibers are the myometrium. So the myoma is still higher. It is very high. It is not submucous. It is subserous. So keep your eyes and observe how the myoma will be exposed. Okay. So cutting into the fundus more. Keep your eyes, and that's it. Okay. So this is the myoma exposed. The patient came after 2 weeks as scheduled and advised, hoping that when I redo hysteroscopy, I find the myoma bulging down and then I can resect. But unfortunately, the myoma didn't come down. This is the myoma. This is after 2 weeks. The myoma is still hanging up there. You cannot reach. Sometimes you get more perseverance and confidence because of the patient trust in you. I remember the patient face before surgery when the tears in her eyes, and she said, "Sir, I am fully confident that you will be able to remove this mass and let me pregnant." In fact, I was trembling, I was shaking, I was afraid, I was hesitant. I know that I cannot remove it. But because of the feelings in the heart of the patient, this charged my energy. I am sure each and every one of you have been in this situation when the patient looks in your eyes and said, I trust you can do it. So I kept my mind working. How can I pull this myoma down? There is no forceps by hysteroscopy. There is no myoma screw by hysteroscopy. But the only thing available in my operating room was the laparoscopy myoma screw. It is 5 millimeters. It cannot go from the channel of the hysteroscope. So I dilated the cervix. I inserted 2 tools, the hysteroscope to see and the myoma screw to start to screw the myoma and pull it down. Let's see that. Sorry. That's a laparoscopy myoma screw. Screw and pull down to deliver the myoma intracavitary. It's coming down now. Look at this.
Fantastic.
More and more, come down, screw more and pull down. Sushma is the only one appreciating the challenge here. You see, working with 2 instruments and pull down.
Wow.
Unbelievable.
Until the myoma becomes submucous and then resected. This is the final view, my friends, and the final video. This is the cavity of the myoma. You see the pinkish muscle fibers, Sushma. You see how it's very clean. There is no charring, there is no burn, and the capsule is excited exactly. This is This is the most orgasmic step or orgasmic view when you see the cavity of the myoma is clean and you get it all out. The challenge was here that how you close this defect. In laparoscopic myomectomy, you can take sutures, but here you cannot. So my only hope is to, when they decrease the fluid pressure, the cavity collapse. This is the myoma bed. Ostium. Look at this.
Oh.
And the cavity spontaneously healed in 2 months. The patient had an IVF after 4 months, and she had a twin girl pregnancy, and they are now about 11 years old. And that's the beauty of life.
Unbelievable, sir.
Really.
I love you all. You gave me one of the most happy, fantastic pleasure hour in my life with you. And I will never forget the memories of Nagpur. And I want my face to come. I want you to see the beautiful gift I still have from Dr. Chimoti, and I will never leave it.
Yeah.
So please, I want another Sherwani. This became old now, all right?
You will get another
And,
one. Next time you will get another one.
I love you all, everybody. Please say hello to Lakshmi, Dr. Lakshmi, and Sunil, her husband, and give a kiss to Sudhir. Tell him that I am missing the tandoori chicken, like always, and kingfisher sometimes, all right? So please take care of yourself, my friends. You have a special place in my left ventricle, and I hope you visit me in Cairo. Here you have a house, you have a big heart, and a family. Thank you very much.
Thank you, Dr. Osama. Really, you have made hysteroscopy very easy for everything. But we all know there are difficulties and so many queries in finding the cervix, in maintaining the flow for the endometrial glow, understanding a limit of distension, medium, and so many things, adjusting the light optimum. But still, I think you have married with the hysteroscope. I will say, because you know every ins and out of hysteroscope. So always I have one linings for you. It's only for you. When there's a me and my hysteroscope. When we enter the uterine cavity, we always talk with each other. Okay, is it a normal endometrium? Oh, that's look like a septum. I can deal with scissors. Okay, electrical current, no problem. That's a surprise polyp, no problem. It will dance with my order. Everyone will obey with me. The distension medium, the instrument, the forceps, everyone will obey me. So myoma, then internal adhesions, everything. So the mission impossible will be, you will make I am possible. So in any difficult surgery, you will make it possible. Thank you very much.
Thank you very much, Sushma. And in every Congress, I always repeat that the second most important woman in my life after my wife is Sushma Joshi. Okay? Because you introduced me to India. I have to say it. All my name and fame is because of you. And definitely Dr. Chimoti, you know, when they brought me to Nagpur, and I loved India. And from that moment, I became Shah Rukh Khan everywhere.
But you are like that only.
Okay. So have a wonderful time. I have a surgery now. I have a couple of myoma resections. So I wish you are here, and give my best regards to Sudhir. Amog, is that is okay?
Yes, sir. He's absolutely fine.
Okay. So I have to go to the hospital now, and big kiss for everybody.
Thank you so much, sir.
Thank you.
Thank you, sir.
Thank you.
Dr. Shobha, ma'am?
Shobha ma'am is there?
Yeah.
Yeah. She faced some initial glitches.
She's there?
Yeah,
Yes.
yeah, she's there. मॅम ऐकू नाही येते आवाज तुमचा.
मॅम बोलू शकता तुम्ही आता. You are unmute. मॅम परत म्यूट झालं.
म्यूट केलं पुन्हा. काहीतरी प्रॉब्लेम येतोय त्यांचा. हा झालं मॅम. पण आवाज नाही ऐकू येत आहे. तुम्ही अनम्युटेड आहात पण तुमचा आवाज नाही येत आहे.
इयर प्लग्स काढून टाका मॅडम.
हा इयरफोन ते काढून डिस्कनेक्ट करा डिव्हाइस मधनं.
मॅम आता पण नाही येत आहे.
चला नेवर माइंड मॅम चलते हैं.
Yeah, so thank you so much, chairpersons, for the wonderful session. One thing that Professor Shawki always tells the beginner is just keep your hand going down and down and down till you see the crescent. So that is the basic tip of entering the cavity. Let the fluid work and just keep pushing your hand down until you see the crescent, the black crescent of the endometrial cavity. So with this wonderful, elaborative and a wholesome lecture on hysteroscopy, of how to do a diagnostic and an operative as well, and introducing us to the different facets of hysteroscopy, including the vaginoscopy, the colposcopy, the proximal fimbrooscopy, I think this has completed the entire conference on a very high note. And with this, I believe that most of the practicing gynecologists would definitely take up hysteroscopy as a primary tool in their day-to-day practice. And with this, I'd like to ask Dr. Vaidhi ma'am for a closing remarks.
Okay. I don't know. It's been so overwhelming. Now I'm really struggling for words to say anything right now. I don't know. It's been, I mean, what I dreamt of. I started dreaming of a physical conference during the mid-February, and we thought now, yes, we can do it with the lowest number of cases in Nagpur. We're all so charged up. The entire scientific committee. Suvarna, you've been with me from the conception of scientific program, and I've been bothering her so much at 12 o'clock at night, 1 o'clock, kabhi bhi phone message karke usko bahut tang kiya maine. But the entire scientific committee worked so hard, and we were like all geared up, taking meetings at AIMS, traveling up to AIMS and meeting ma'am and in the department. Se leke har ek cheez ke liye we planned special delegate gift for all our delegates. We had planned a PPH and eclampsia kit as a gift from us from Gynecon. And then there were so many things happening, and suddenly the corona friend dropped in again and पूरा हमारा mood खराब कर दिया. Nonetheless, again थोड़ा सा disappointment से फिर से खुद को push किया. And these girls pushed me कि ma'am चलो redesign करो program. We can't have the entire session again. And I'm glad whatever we planned, it was a grand success. I feel all of you enjoyed. I hope you all enjoyed. It was an academic treat, starting from Evita ma'am to the magician Osama. So thank you all so much. It's been an incredible journey right from 1st of April till now. We have another 2 weeks to go. We will bother you for the next 2 weeks also. इतने जल्दी छोड़ेंगे नहीं आप लोगों को. आखिरी दिन तक तंग करेंगे and फिर आराम करेंगे थोड़े दिन के लिए. So thank you all so much. I'm actually struggling for words. I'm not इतने सारे मन में thoughts है but वो आ नहीं रहे properly. But thank you so much. Thank you. वो बोलना भी नहीं हो रहा क्योंकि इतना ज्यादा support, encouragement, love आप लोगों से मिला है तो कितना भी thanks बोलूं तो भी वो कम है. I love you all and value everyone's presence in my life. Thank you so much.
Thank you so much, ma'am. That was Seedha Deal State and a wonderful note to end on. And with this, I believe it marks the end of the Gynecon 2021, the first ever virtual annual NOGS conference. And kudos to the entire VR team to start with the virtual webinar, virtual meetings, and end the session also, unfortunately, on a virtual conference. But then again, हम सब तो टेक्नोलॉजिकली savvy हो गए. Our society knows how to use Zoom very efficiently now. So thank you, ma'am. There is always a silver lining to a dark cloud, and this has definitely proven to be it. So thank you so much, ma'am, for the wonderful opportunity you have given us to be projected on a national platform. And I would like to remind everyone who's logged in today that NOGS has been the society who has been portrayed on the digital webinar map of the country. Every society is talking about the NOGS programs and the webinars that have been conducted weekly over the entire year and tenure of 2020-2021. So with this, we sign off and hope to see you soon next week again. Before that, day after, we also have a program, and on next Sunday, we'll be engaging you with all the awards and the valedictory for today's conference. So thank you so much once again.
All of you have to log in next coming Tuesday and next Sunday for some exciting program.
Thank you, ma'am. Thank you once again. And I must say that, you too, VR world, you're the spice and salt of NOGS, and you're definitely going to affect the taste of NOGS. You rocked. Had a wonderful day today.
Thank you, Lakshmi. वो हड़बड़ में ऐप के थोड़ा सबको बताना रह गया. ऐप का आइडिया इसलिए आया क्योंकि हम लोग डायरेक्टरी बना रहे थे. एंड सुवर्णा मैम पेपरलेस करना है साल भर का गया इसलिए. एंड मैं नहीं यार, एक तो कुछ तो फिजिकल फॉर्मेट में छोड़ के जाएंगे. एंड फिर दिमाग लगा रहे कैसा करेंगे, बहुत सारे ऑप्शंस ट्राई किए ये डायरेक्टरी लॉन्च करने के लिए, कुछ भी नहीं जम रहा था. एंड ये ऐप का आइडिया आया. And the entire, of course, it started because we wanted to launch the e-directory. With the app, there is going to be lot of happening on the app. It's going to be birthday reminders, anniversary reminders, calendar, direct phone calls. The contact list is so wonderfully put in. You just type, if you want to call me, just go type Vaidehi. And on that page, you will get my contact, my address, my email ID. And there'll be 3 icons on the page: mail, WhatsApp, and call. So if you just press on the call button from the app, you can call me. From the app, you can email me. From the app, you can WhatsApp me. There'll be everyday notifications of, there'll be a backend admin. If you like how Rajasi puts every day the greetings from us, every day, all through the year, we've been wishing each and every member. From this year onwards, we have made it a little easier for Alka. She just has to, from the backend, push the notification. And once you open the app, the first thing that will appear is the birthday of that day or the anniversary, and any announcements that she has to make, that today this is the program or whatever. We can take multiple polls. We have posted all the links to the website, so you can directly view all our recorded sessions from the app itself. So there are lots and lots of things happening. But the app happened because the directory happened. And the one man army behind the directory is this gorgeous lady Suvarna. उसने सिंगल हैंडेडली काम किया. मैंने उसको तो बहुत तंग किया साल भर. मतलब वो मेरे को लगता था डरेगी मेरा फोन देके, आ गया मैडम का फिर से फोन. बट मैंने उसको मतलब ऐप के लिए, डायरेक्टरी के लिए भी और साइंटिफिक के टाइम भी उसको मैंने बहुत बोर किया. रात को सुवर्णा ठीक चल रहा, कह रहे अरे मेरे को बोर हो रहा है, अपनी सब लोकल फैकल्टी कैंसिल हो गई, कैसे लगेगा, क्या लगेगा. एंड शी इज बीन लाइक पुशिंग मी, नहीं नहीं मैम ऐसी करो, अच्छा लगेगा. सो सुवर्णा, थैंक यू सो मच. आई वैल्यू योर हेल्प. Directory is all because of Suvarna's undated efforts. Right from day one till almost the last few days back, we've been after the directory, asking people to update. Please update karo. Arre, please contact correct karo. Birthday correct karo. And she's been after it. So that in that complete rush, I think we forgot to mention that. But kudos to you, Suvarna. Thank you so much.
Chalo, good. It was a great conference. Great topics. Good audience and enjoyed all the topics.
Yes, सही में.
खूब अच्छा. OSAMA was the final.
वो तो pinnacle रहता है ना उसका, वो magician. No wonder he's called the magician.
खूब अच्छा. Good.
मजा आ गया वैदेही. Well done.
Thank you Lakshmi. Thank you. Thanks so much.
म्हणजे फिजिकल नाही झालं तरी पण व्हर्च्युअल खूप छान झालं.
Yes. Short and sweet. थोडासा डिले झाला 1 तास, but that was expected.
पण ठीक आहे ना, एव्हरीबडी वर एट होम ना, ऍट इज.
येस. आणि होतच तेवढं, म्हणजे 15-20 मिनिटं पहिल्यांदा ते गेले टेक्नॉलॉजिकल इश्यूज मुळे, मग अर्धा तास लेट तसंच झालं सुरुवातीला.
काही नाही,
तरी स्मूथ झालं ना, स्मूथ सेलिंग.
नथिंग, नो मेजर ग्लिचेस.
वैदेही स्वतःला ट्रीट दे आणि शांतपणे झोप आणि एन्जॉय कर. आज कोणालाही फोन करून बॉदर नको करू.
उद्यापासून मी यामिनीला आत्ताच मेसेज केला, आज आराम कर, उद्यापासून तुला त्रास देणार आहे मी. आराम करायची परमिशन.
चलो बाय. चलो अमोघ, यामिनी, शिवानी, ऑल गुड. बाय
बाय मॅम.
बाय. अमोघ, थँक्यू यार. सकाळी तू इतक्या घाईत त्या ऍपचं बनवून दिलं मला तर अगदी हार्ट अटॅक याचीच वेळ झाली होती. एक तर त्या अँथननी मला अगदी हार्ट अटॅक आणला होता. सकाळपर्यंत मी मरमर करत होती त्याच्या मागे. तर दिनेश मला इतक्या शिव्या देत असेल की तुला काय सांगू. पण ऍप तू पण फटाफट करून दिलं सकाळी मला तो व्हिडिओ. थँक्यू. इतकी तुम्ही सगळ्यांनी मदत केली की कोणाला किती थँक्यू म्हणून हेच कळत
म्हणाला ना, व्हर्च्युअल मुळे आम्हाला झूम आणि हे सगळं टेक्नो सॅव्ही झालेला
नाही. हे लोक इतके सॅव्ही आहे, इतके ट्रिमेंडसली टॅलेंटेड आहे, सगळे फुल कम्प्लीट आहे सगळं. आजची टीम, कालची टीम, काहीच्या काही टेरिफिक लोक आहेत.
गुड. Alka is going to get a good team. Nice. Chalo, bye.
Dr. Sunawala ma'am, thank you for being there through the year. You've been attending all our programs, but the app is only for the NOGS members because it is coded. All our members' phone numbers are fed into the app, so only those who are our members will have access to app, just for the privacy and security reasons. But thanks for that comment. That app is called NOGS Click. I think, as always, suggested some catchy names have always been suggested by our very talented secretary ma'am. So that even Noogle was named by Rajasi. NOGS ka Google, Noogle.
Chalo. Bye.
Chalo, bye.
Will you the host?
Yes. I'll do that. I wanted to extract that. Yes, thank you, Mamo. चलो तुम लोग लॉग आउट हो जाओ, मैं वो थोड़ा इतना लेके फिर लॉग आउट करती हूँ.
चलिए, बाय मैम.
बाय. थैंक यू सो मच.
थैंक्स अमोघ. चल बाय.
थैंक यू मैम. बाय बाय.
अमोघ, are you there? Oh, गेला. तुला होस्ट करू का मी पुन्हा? अमोक तुला होस्ट करू का पुन्हा मी? तू म्युटेड आहे. तुला होस्ट केलंय मी.
हा ओके मॅम. पण आता
ते रेकॉर्डिंग थांबव रे, रेकॉर्डिंग चालूच आहे आपलं.